Cancer Center Grand Rounds. And we're very fortunate today to have two really very interesting areas that we're going to focus on, both of which in some respects rely on the coordination between clinical care and research in terms of sample collections to advance great science. And our first talk is emblematic of that important concept. I guess, Bill, before I start, I should point out the slide that Dr. Lynch, my predecessor and my classmate in fellowship, will be talking tomorrow. So tomorrow, right? If for those of you who want to attend. But let me open up with our first talk. Which is it? Is this you? Okay, excellent. So I think one thing we really wanted to do in the past 2 years is to make sure that we enable great science through interactions between our growing clinical operation and laboratories, between our clinical trials and individuals who are trying to understand sensitivity and resistance. And our colleagues who will present today are going to share the work they're doing with our clinical research support laboratory. So roughly about a year ago, Dr. Stephanie Halene took over as the director of our CRSL. And Stephanie, as you know, is an associate professor of medicine. Her laboratory has done invaluable science understanding the biology of leukemia, myelodysplasia, and how to leverage that biology to define new therapeutic approaches. And I'll let Stephanie open and then introduce colleagues who are advancing the mission of the CRSL to expand our portfolio of science.
Thank you. Okay, well, thank you everyone for coming today. So this is a joint presentation between myself and Debbie, and Talia has not been well, so I'm presenting on her behalf, but she gets all the credit, and every mistake, it's all mine, okay? So we're the Clinical Research Support Lab, or CRSL, and how do we make research happen? Well, so you may wonder, what do we actually do all day? I can tell you we're busy, we're doing great work, and we have a vision for the future. So Rocco kindly provided me with this history, which is, I think, very helpful to understand where we are now and where the CRSL and research at Yale is coming from. So, understandably, it all started, with a clinic and then basic science lab. So a blood sample would just walk over itself to the basic science lab and then be processed and, generate nice data. At some point, though, people realize that there need to be people helping with that because it can't just be a postdoc walking over all the time. And so then the clinical trials office staff actually dealt with the patient, consented, told them about trials, etc. And then the clinical trials office staff actually walked the sample to different basic science labs at Yale and processed the samples. And in around 2006, Nancy Harris, then director of breast oncology, and Kevin Kelly, director of geo-oncology, had this idea that there really needed to be a central lab processing these specimens because things were getting more complicated. And so they founded the cell processing lab and hired Rocco Carbone, research specialist. And I was at Yale for quite some time. Everybody knew Rocco, and everybody still knows Rocco because he is just a wonderful, wonderful resource. And so N of 1, Rocco started processing clinical trial samples with a desk and a bench. And then Howard Huxley took over as CTO, Clinical Trials Office Director, and he founded the Clinical Research Support Lab and hired Lynn Bachwalder as the CRSL director. So then Lynn and Rocco, two people, started processing about 40 clinical trials. And you can see in the picture, around this time, Smilo happened and changed everything. And so then over the years, the trials went from 40 to something around 400. Staff grew from 2 to over 28. And Rocco stayed with the CRSL and just had his 35 years at Yale, so congratulations. And it's a wonderful, wonderful resource. Lynn actually moved over to the Rapid Case Ascertainment Group and is, we're closely collaborating with her there. And then we were so fortunate to have Talia Mitchell join us as administrative director of the CRSL. and Debra Nickischer as the technical director of the CRSL. And they're now making things happen when my life is incredibly easy now. So this is our current structure. So again, we're the Clinical Research Support Lab. And as you can see, we're very centrally located between the Clinical Trials Office and research happening. And we kind of have a division, but this is a unity. We work as a very close team between kind of a dry lab team, and I'll tell you on Talia's behalf what that is about. And then we have a wet lab team, and Debbie will tell you about that. So when our physicians have smart ideas or medications that are very, very interesting bringing to the patients, that comes with stacks and stacks of papers, so clinical trial protocols, and of course also with laboratory manuals with many, many pages, and then cute diagrams that somehow have to be translated into the clinic. And this is what our project managers do. And currently Talia and Rocco are helping out because we are swamped, but we're doing it. And so our project managers take these laboratory manuals and translate them into your favorite electronic resource and what's to come, Beaker and Beacon, etc. And eventually our clinicians are able to bring these new medications to our patients. So what does our project manager team do? They review the clinical trial protocol and the manual. They review for feasibility. They build the EPIC Beacon build and they review it. They construct templates. They provide workflow instructions for blood, tissues, and anything else involved with samples for the clinical trials. And then I'll show you pictures of kits. So every trial comes with a lot of kits and a lot of tubes and a lot of paperwork. They transfer files so that we can communicate electronically. They are part at kickoff meetings. They're very, very closely integrated with disease teams and the clinical trials office in many meetings. They're very critical to all communication between physicians, patients, clinical trials office, sponsors, central laboratories. And of course, there are always questions and they answer them all. So this has all gone, again, from 40 studies to 280 open studies that are enrolling patients every week, every day. And we have about 400 active studies, meaning studies that are either pending, so being processed right now that nobody knows anything about, or studies that still have patients but are maybe close to accrual. And so I told you about kits. So when people think inventory, they think about this. Yeah, boxes stored somewhere, nobody has to look at. But that is not true. Our inventory is live inventory. So we have all these boxes that are full of tubes and paperwork that have to every day go to the clinic. And probably about 100, 120 of these kits go to the clinic every day, then get set up on racks, and Debbie will tell you all about that, deployed to patients, and then the samples get shipped back. So just recently, we moved from this kind of dead storage where people say, like, why is my study not accruing, to live inventory. And we just moved temporarily to over 2,000 square foot location in 100 Church Street South, which is a bit far away, but we have, couriers and delivery assistants. And that is actually thanks to Bruce McCann, who's really helped us out. So, so what happened to these things, to kids and all that? Well, as you can tell, everything has been growing in Smilo. So we went from, a few kids, a few studies, to something like 16,000 kits that we now have. About 2,000 kids go in and out every month. And again, about 100 or more kids go to the clinic every day. And this is pretty much a straight line up. So as people open more clinical trials, this is definitely growing. And we're trying to keep up. We're trying to get ahead, and we're trying to make it happen. So let me hand over to Debbie, who can tell you the wet lab.
Okay, can everybody hear me? Okay, so like Dr. Halene said, I am the technical director of, you can't hear me? Okay. Works. Is that better? Yeah. Okay, thank you. I'm the technical director of the CRSL. And what we're really doing is we're working as a team with the whole clinical trials organization. As Stephanie mentioned, we're putting together all these study protocols. And remember, she was talking about, over 289 active open studies right now. that we have to work with everybody from the principal investigators to the DART teams and our project managers put all that together in a lab manual, and they're forming the templates that we use in the lab to collect the samples. So once the DART teams have the studies open, they actually schedule patients that are eligible for the studies to come in, and they send us treatment schedules. Whoops, that went too far. They send us treatment schedules so that we know the patients are scheduled for certain days. This is where the CRSL comes in. We incorporate and coordinate all the visits for the samples that are coming in each day. We plan it a week at a time as much as we can, but there's always updates and changes that we have to keep track of. And we are basing these on the protocol and the lab manuals for each individual study. We have a scheduling team that has just been formed, Marissa and Sarah, and they are ordering study-specific kits according to the lab schedule that we form. They prepare the visit templates for each individual patient, and they prepare the sample collection racks for each individual visit that is required for each day. And then we have transporters that deliver all these racks to the individual clinics and floor locations so that when the patients come in, it's ready for them. And again, we are collecting blood, bone marrow, tumor biopsies, BALs, stool, urine, anything that's required for a certain trial, we will be collecting those. Okay, so what do we actually do in this wet lab? First thing we're going to do is transport the tubes to the lab from every area of the hospital to the lab where we were going to go ahead and centrifuge aliquot blood, making sure that we follow the study-specific lab manuals. And again, remember, we're looking at over 289 lab manuals that we're looking at. We need to have study-specific kits and documentation and shipping instructions for each study. We also support collecting biopsies and processing those and shipping them out appropriately. So that means that we are going into the ORs and working with the surgeons to make sure that we are collecting the biopsies appropriately. Our number one priority is the patient and their samples. We want to make sure that we're taking care of their precious samples, not only for their health, but for the future of the research of cancer research. At the same time, we're making sure that the patient is safe, that we are working appropriately and safely with those biological samples, that we are filling out the appropriate documentation, we're following HIPAA rules, and good clinical practices, and that all of our staff are certified for shipping these samples out anywhere in the country or the world. This chart here is just an example of the last 2 months that we've been processing samples here in the CRSL. It is organized by date and processing time. So a lot of the dots are interlinked here, but you can see the bigger the line is, the more patients there are. The X's are the median number of samples that we have, and then it's spread out by the time it takes to process each sample. So you can see that there's a couple samples in here that are taking hours to process based on what the protocol requires. And there's some that just have an ambient sample that needs to be shipped. So it's very specific per protocol what we're doing. I'd like to give you some idea of how we're advancing our lab. So a recent advance that we did, we've actually changed all of the lab manuals to a digital form. So if you can picture 289 3-ring binders all lined up in the laboratory. Now that we've gone digital, all the lab notebooks are gone from the laboratory, and we have these Surface Pros at each workstation, and the lab techs can go into each Surface Pro and go into our shared drives and open up the protocols and follow the lab manual step by step as they're processing the samples. What we would like to do in the future, and we are looking into it this year, is kind of going into 21st century, provide some LIS, laboratory information software, that can track our workflow, increase our efficiencies, and eliminate paper. This is a group picture of our staff in the wet lab in the CRSL here in New Haven. So we are growing. I'm happy to announce that we have a lab manager that just accepted the position, so she'll be reporting to me and managing the day-to-day activities in the lab. So where are we? And this is really fun, so follow along with me here, okay? So our main wet lab is in Smilo North Pavilion on the 8th floor. And we also have another wet lab on Cedar Street. So, we're actually taking specimens in on the 8th floor of Smilo and then bringing them to the wet lab on Cedar Street in order to process them. We have, a split staff on both sides, but in order to get the bulk of the work done, we have to move to Cedar Street. There just isn't enough space for us all to do it in one space. We also have a space on the 11th floor right above us in the North Pavilion that has been typically used for storage, but we are converting that to a scheduling and tube setup area so that we can have more room in the NP8 lab. You see we have some other storage facilities that in the past we've used all the way on York Street. We don't use those anymore. And we also have a storage space on LLCI, which we are using for shipper storage. If you can imagine all these big boxes, and each study and each sponsor wants us to use certain boxes to ship them out. So we need lots of space for shippers. And then as Dr. Halene mentioned, at 100 Church Street South, we have the individual kits that need to be delivered to the lab so that we can make the collection racks and send them out to the floors. So in addition to everything that we do here on campus, we also have care centers. So Yale Smilo is all over the state. Well, before I even go there, let's talk about those challenges. So our challenges are the distance between the supplies and the lab. So I've already mentioned we're going between those areas. And then the distance between the lab spaces and people. So there's lots of challenges in timing, if you can think about that, how it's going to go from the patient to the lab and back and forth so that we can make sure these samples are being processed appropriately. So here's our care centers. Smilo has care centers all across the state. You can see that we are looking at anywhere from Torrington to Trumbull to Derby, Orange, Guilford, Waterford, and Hartford. So what we found was, and it's pretty obvious, as the distance from New Haven increases, the time for us to process these samples decreases. So what we did for 2 locations, Trumbull and St. Francis, we opened satellite CRSL labs. So they are staffed with a lab manager and a lab technician in each lab, in each location. Now, we couldn't do any of the coordination here up until now without Joe's help. He is our person that is coordinating all of the care center schedules, couriers, and you can imagine how many couriers we have to go to all these locations. Some of them are doing it like in Trumbull and St. Francis on their own, but we still have to send them the kits. And then the other locations are actually still sending us the samples. There's a lot of coordination going on. These are our 2 Trumbull and St. Francis labs, staffed by John and Maria as lab manager and Peter Gay and Joelle as lab technicians. And just to give you an idea of our hours and our limiting factors. So our New Haven site is open from 7 a.m. to 8 a.m. to 7 p.m. Monday through Friday. We are available for later hours for later PKs, and we are open weekends and holidays as the schedule requires. We have the capability of processing samples within 15 minutes of draw. And of course, with late PKs or PKs throughout the day, we can do 12 hours post-treatment. We're even talking about 13 and a half hours at this point. So, what you need is we'll figure out how to do it. The samples are also collected at bedside, during surgery for biopsies, interventional radiology, and things like that. And we have the ability to add stabilizing reagents to the samples before they go out to where they need to go. We also are supporting other labs within Yale. So if you're, Dr. Halene will talk about that as well, but we will take the samples in and process what we need to, but then we will send them to the appropriate labs like Dr. Halene and Schalper and Kluger and Sklar. So there are options for other labs if you need them. Our Trumbull and St. Francis hospitals, there's the challenge here. So, this studies that are done at these care centers are chosen. so that the timing can be done right. They can process within 15 minutes of collection, but the CTO itself isn't open that long. So they can really only do 6 hours of PKs during a day. There is some biopsy type issues that have to be specific per site. And there's some limitations like fume hoods and number of collections per day, that type of thing that you have to consider when we're doing these care centers. The other care centers, Fairfield, North Haven, you just look here at the distance it takes to get the samples to where we need to go for processing. And then, of course, we've been alerted to the addition of Greenwich. That should be coming this year. So we'll have to decide. We're looking at 45 minutes away. So we're going to have to decide if we're going to open up another lab there or how the processing will be done, depending on what type of trials will be done there. Wow, really excited one about that.
Okay, so I think what you can tell is that we're truly a clinical research support lab, and we're supporting SMILO care centers, sponsors, pharma, gives us the drugs or even investigating trials. We ship things, we connect to laboratories, and so the question is, can we do more? And our vision for the future would be, could we potentially be a central research support lab? So can we maybe make additional research possible where we can now maybe provide pilot studies for people, help people with investigator-initiated trials, or whichever way. So so we hope that is possible, and we're open for questions or suggestions, and what we're doing now, how we can improve things, and maybe vision for the future. And Debbie and Talia was here, so if we have a little time, feel free to ask questions.
Thanks, Stephanie and Debbie, for presenting. And let me start. I can certainly open the questions, namely, as we expand our network and realize that there's a growing population of patients, how do you envision we sort of cover the ground? I mean, you talked about having 2 CRSLs now. Is the solution to just build more CRSLs or figure out efficient courier services or some combination thereof, or other creative solutions?
I think it'll depend mostly on what we're envisioning each location to achieve as far as patient work, load that's going to be offered these clinical studies. So, for instance, in Greenwich, and I think the distance is a major factor of it as well. We are just in the beginning stages of Greenwich, so we don't know how big the facility is going to be as far as how many patients are going to be seen every day and what kind of accrual there'll be for different studies. I think it's going to be a case-by-case basis. And for example, Waterbury is really too far away to transfer those samples. So if there's going to be more accrual there, we're looking at different alternatives like the clinical lab processing the samples and the CTO shipping them out if opening a lab is not feasible there. And I think, again, it's workload. So if there's too much going on, I don't think the clinical lab's going to want to do it. So then, if finances are available, then we would open a lab. I think it goes in steps.
How are you handling, I know you say as needed, sometimes the biopsies are delayed, that happens all the time, and quite late. Is there a mechanism now for making sure that it's processed properly?
Probably not as good as we'd like. I think the huge indicator is communication, especially when they're delayed. We had a tech have to stay right around Christmas time to almost 10 o'clock because of a delay. If we knew about that sooner, there could have been more organization to say, she could have gone home for dinner or something like that. But anything that needs to be done is for the benefit of the patient, so we'll always work it out.
Right. And some of the teams, especially the SCORE groups, have their own teams that do some of this. They coordinate very carefully with you on that, and maybe one group will cover up the other, perhaps.
You're talking about like CTTS or?
Well, like lung SCORE, I know.
Lungs.
Has people that will go to the biopsy. So
Okay.
if they go, I guess your group doesn't have to go, or how do you work
It
that?
depends on the actual study protocol, the lab manual, as to whether we go or somebody else goes.
That could be a mechanism
Yeah, I think, for example, some of that is happening in hematology already, because for the hematology trials, we actually don't have the space to do the processing in the labs we have right now. So my lab actually started processing. So we have a technician in my lab location processing bone marrow biopsies that need to be FICOL and just need longer processing. So there is some synergy. I think now that we again have Debbie, Talia, and a lab manager, I think that we just need to be sure that we organize it better, that we make sure, we have monitoring, we have, SOPs, that we really formalize this process. And I think that's also something we're trying to do now. And so then, yes, we could then work with other research labs to maybe maximize what we can do together.
Yeah, just to clarify, are you available for HIC-approved studies that are not clinical trials?
Good question. I think we may have to pass that on to.
It's a conversation, David, that we're really starting to think about. Stephanie and I have talked about it. Roy and I were talking about it this morning. How do we build off of the great work that the CRSL is doing to further enable translational research? Obviously, there's a great effort that Joanne has been championing to build out our translational research infrastructure. And as we continue to advance this, maybe we leverage the lab to help us enable that. And I think that's an opportunity we should look closely at.